Several things to talk about right now. We have the Christmas season coming up. And like we said before the Thanksgiving break, we're concerned about what might happen over the Christmas holidays. And unfortunately, our concerns over Thanksgiving were realized. We've seen a bump in cases, not only throughout the country, but in Alabama and especially here in Jefferson County. And as we thought, there is a strain on our healthcare systems all throughout the state, and especially again here in Jefferson County. We are seeing unprecedented numbers of cases of COVID in our hospital. So what we're really concerned about right now is what is going to happen in the week, especially the second week after Christmas. And if we all collectively have the same type of exposures that we did over Thanksgiving, we can expect a doubling of the cases that we have now. So if we're already stressed coming into the Christmas holiday, we're going to be stressed times 2 about 2 weeks after Christmas. And the sad thing to, I think, all of us is that we have a way out. This vaccine is here. I got mine on Sunday. And I think we'll see this rolling out to the population in our state in larger and larger numbers into January, February, March. And what that's going to mean for us is an end to the pandemic, perhaps as soon as the summer, and certainly by Thanksgiving and Christmas next year, if we all participate in the vaccine program. But we've got to make it till then. And so what I would like to do is ask everyone throughout all of our communities to rethink Christmas plans. And if you're planning on traveling, rethink that. Do you really absolutely need to go? Is it essential for you to leave your home and go someplace else? Is it that important to have a large crowd at your house? I would suggest keep the number of people at your home down to 5 or 6, perhaps in addition to your core family. But it's best if we minimize our exposures to others. And that's going to help us all at the end of the day, especially in 2 weeks, as the post-Christmas holiday happens, the stress on our healthcare systems and the stress of illness among people in our community. I'll finish with one other anecdotal comment. I'm dressed in scrubs today because I'm headed over to our COVID outpatient clinic as soon as I finish here. We're seeing our numbers there increase. A universal story is a patient comes in and they said, I thought I was being really careful, and I was up until the holiday, and then I let my guard down, and now I've got this. And I can speak for every one of the patients that I'm seeing and saying that it's a scary experience. Nobody wants to go through this. You don't know what the next day is going to bring, much less the next hour, in terms of increased symptoms. And my final comment, there's something new that we've discovered called long COVID. What that means is that there's a proportion of people who make it through their acute illness. They might not have even had to go into the hospital, but starting about 4 weeks after their symptoms first started, they continue with an illness that lasts sometimes for months. And we've seen it go out 5, 6, 7 months after an initial illness. And it's fatigue, and it's shortness of breath, and a fast heart rate, and a low blood pressure that causes tremendous symptoms and a lot of neurologic things. So long after this pandemic hopefully is over, long after it's gone, we're still going to be seeing patients who are going to suffer from having had COVID and not quite being able to shake the symptoms. And that's not a huge number of people, but my guess is about 5% of people who've had acute COVID have some lingering symptoms that go on for weeks to months. We can prevent that. How? By not getting infected in the first place. So I'll pause there and take any questions. Thank you for allowing us to have this opportunity, and I look forward to hearing your questions.
Great. The first person who's put in the chat is Mike Royer with WVUA. So feel free to ask your question, Mike.
Good morning, Dr. Slagg. You hear me just fine?
I can. Thank you, Mike.
Dr. Slagg, thank you for giving us this information, helpful information today. I'll ask a two-part question and then just sit back and listen. One, have you had the first vaccine, first of the two vaccines yourself? How did that affect you, if at all? Second part of my question is, when I go out on stories or walk around Tuscaloosa here at the University of Alabama, I just kind of unscientifically ask people, hey, when it's your turn to get the shot, are you going to get it? And I'm a little concerned about the number of people going, no, I'm not going to get that shot. And then they'll tell me why. And it's a variety of reasons. Would you give me that soundbite I need to play on our newscast that tells people that say, no, I'm not going to get it, why they really ought to rethink that? Thanks for answering those questions. I'll mute my microphone and listen. And thank you again.
Thanks, Mike. Yes, I got my shot on Sunday morning at 7:15 a.m. It was a very smooth process. The folks here have done a marvelous job of organizing the process, and the vaccine itself, that process was easy. The shot didn't really hurt. I waited for the 15 minutes afterwards, and I didn't have a reaction and left. In my case, I did develop symptoms of side effects of the vaccine on Sunday night that were somewhat like the acute illness that I had without the respiratory problems. I had some chills and fever, and I felt bad for about 18 hours, and then it went away. So I'm feeling fine this morning. And despite that, I would say I'd get the vaccine again in a heartbeat. Why? Because it's our way out of this epidemic. The studies that were done were rigorously performed, and I've followed those every step of the way. They show a remarkable efficacy, 95%. But what that looks like, if you look at the graph, if this is the group that got the placebo that didn't get protected, this is their number of cases. It mirrors what we see in the community going up. And this is what the people who got the vaccine look like. You don't need to be a statistician to know that that's a big difference. So these vaccines work. The next question is, are they safe? Well, there are side effects that are reported, the most common of which are either no side effect at all, soreness in the arm, or some redness at that site. And those are the most common. There's about 20% of people who, like me, got a little bit more in terms of fever, chills, and body aches. But that was expected, and I knew that that was something that could happen. And it's really, at the end of the day, not a big deal, especially when we're comparing getting a vaccine versus getting active COVID. So it's not like saying you get the vaccine or you don't get the vaccine, and if you don't get it, nothing can happen to you. That's not the case. You will remain vulnerable not only for your own illness, but you can bring that illness home to your family. And while you may do okay, your other relatives might not. So if you're trying to protect mom and dad or grandmother and grandpa, you need to make sure that you're safe yourself. And the best way to do that is to get a vaccine. The vaccine will only get rid of this epidemic as if at least 70%, 80% of us across the country get it. So I think it's on all of us to do that. And finally, the people who ran the studies, the people at the NIH, Tony Fauci, Francis Collins, Alex Azar, the head of HHS, and the public officials in terms of the Surgeon General, all got vaccinated. The first three got vaccinated today. They're stepping forward. They're not just telling us to get vaccinated. They're doing it themselves. They're putting their money where their mouth is. They're stepping out in front of this. And I think we all need to do that. I'm happy to provide more information on the safety of the vaccine and its efficacy, its effectiveness, but we really need to do this. Otherwise, this epidemic continues to explode in our country, taking countless tolls of life, in my view, unnecessarily. We need to stop this, and this is our way out. A final point. Everyone who's questioning the vaccine should ask the question, what if those vaccine studies had failed? What if we didn't have a vaccine available to us right now? What if we had not, in great wisdom, parallel tracked the studies with the production? Because otherwise, if this were a normal development of a vaccine, we get the study result, and then we would trigger producing enough to vaccinate people, and that could take yet another year. So in our case, we have everything we need right now to end this epidemic. but it's going to be up to us to do it in terms of sticking out our arm and getting vaccinated. So I plead with everyone to get vaccinated.
Thank you. That was fantastic information to share. I'm going to go over to Jay Reeves with the Associated Press. He asks, does there appear to be an increase in deaths as some measures seem to show?
Appear to be an increase in
deaths as some measures seem to show. So numbers seem to be going up in the death count. Is that what you're seeing and hearing? What are your thoughts?
Yeah, we are seeing increased deaths. If we look at the actual rate of death, it's lower now than it was, say, back in March, April, and May. And the reason for that is that we know more of how to manage patients, but still those death rates become overwhelmed in terms of the number of patients we're seeing. So if someone gets exposed today, it's going to be 5 or 7 days before they develop symptoms. Then it might be another couple days before they get tested. And then if they're going to be hospitalized, it's going to be about another week after that. So we're talking about a 2-week lag. The deaths lag by another 2 to 4 weeks. So what I'm expecting to see in Jefferson County and throughout our state over the next 3 weeks, based on this Thanksgiving surge, we're going to see our death rates, or the number of deaths, increase pretty substantially. And across the country right now, we're having around 3,000 deaths a day. And when you think about it, that's equal to a 9/11 every single day. Every day, we have the same number of people dying from COVID as we had on that one day back in September 2001. That to me is unacceptable. And we have it in our power to bring it under control by doing the things we know to do in terms of avoiding crowds, wearing masks every time we go out, and making sure that we're keeping distance from other people while we are out. And the second thing we can all do is get vaccinated when the opportunity arrives.
Thank you. Eddie Burkhalter with Alabama Political Reporter asks, are you continuing to see younger people becoming sicker with COVID than earlier in the pandemic?
We're not seeing, again, the rate of younger people getting sick with COVID, but again, the numbers are overwhelming the rates, so that the number of people who get sick, let's say 1,000 people get infected, it might be among young people 50 to 100 at most who would get sick with it, and then even a smaller number of that who will get hospitalized, and then the number of deaths are smaller still. But when you see not just 1,000, but 10,000 or 100,000 young people getting infected, all of that increases proportionately. So yes, we're seeing younger people coming into the hospital in numbers now more than we've ever seen, not because the virus has changed and not because anything about the care of this has changed. It's just simply we're getting overwhelmed with the number of people infected in the first place, and that's translating into hospitalizations. Another thing that I've noticed that the public has gotten a little bit turned around on is that when we stressed the higher death rates or the higher probability of a death among people over the age of 65, everyone said, a lot of people said, well, I don't have to worry about it if I'm 30 because it's only the older people who die. That's really not true. It was a relative number. So yes, there can be up to 20% of deaths of people who get it over the age of 80. And it might only be 0.2% for a young person at age 30, but it's still possible. And unfortunately, it still happens. And that's what disturbs all of us. So everyone should try to prevent this infection, not only because of protecting ourselves, but as I said earlier, protecting our loved ones around us.
Thank you. I know that we've gotten this from a few people pre-submitted, but can you just talk about this virus mutation that we're seeing in England, if there's reason for concern about that coming and spreading in the United States? Really just kind of give us the down low on what you are hearing about this virus mutation.
Sure. So backing up a step, we know pretty well from the study of HIV and a lot of other viruses that we call RNA viruses, we know that they mutate. very commonly, very frequently. And usually it's in response to the immune system trying to kill it. So the virus, as it reproduces itself, might just by accident make a mistake in its transcription, so that it's like if you're copying down the Bible, trying to go word for word, you're going to make an error every now and then as you try to transcribe that. Well, the virus also makes mistakes as it transcribes itself in its reproductive process. And just by chance, if one of those changes, one of those mutations has an advantage over the original virus, it outgrows that original virus and becomes a predominant virus. That's precisely what happened here. It's really Darwin's law of evolution, but on super fast forward, because normally we think of evolution as taking centuries to have a change in a species. In the case of viruses, that change can happen over a period of days, weeks, months. And so what we're seeing in Great Britain right now is not unexpected. In fact, it is to be expected. Another point is that the virus that originally came out of Wuhan back in December and January of 2020, that virus is probably no longer seen anywhere right now. Rather, the virus itself mutated to a version that hit the East Coast of the United States is a very different virus as far as actual structure than the original Wuhan virus. So what we're seeing now out of Great Britain is just a variation on that theme. What does it mean for us? Well, once a virus with increased ability to replicate comes out, what that means is it becomes a little bit more infectious. So that if you got exposed to it, ordinarily, perhaps it might not have taken hold. It could have tried to infect you, didn't make it, and that's the end of that, and you never get infected, you don't get sick. The virus that is mutated binds a little bit more tightly to the lining of our nasal passages, and therefore, as it binds more tightly, it's less likely to just kind of fall off and disappear. It binds more tightly, and then it has a higher chance of infection. And that estimation is about 40 to 70% more likely on a given exposure to infect. What can we do about it? Protect ourselves, wear our masks, avoid going out unless we have to. It's not something we should necessarily fear, but we should respect, just like we should respect this virus all along. And we know that the vaccine is coming. The vaccine will work, as far as we can tell, against these mutated viruses from all the evidence so far. So just hang in there, but do the things we know to do, especially if that mutated virus is around. Another question that's come up is, has that virus entered the US at this point? And would a travel ban help us? In my estimation, this virus was here a while ago, probably several weeks ago, because travel was going on. So I think to have a travel ban right now might make us feel good, but I suspect that it's already here. And the only way, or the best way to stop it, is to protect ourselves by doing all the things we already know to do. It's just a question of doing it.
Thank you so much. Great answer and great thoughts. We've had WVTM and AL.com ask about the surge after Christmas. So to combine those questions, can our hospitals handle that kind of surge that you're anticipating and others are, based on what we saw at Thanksgiving?
Every hospital is different. I can speak about UAB. We've had a really remarkable group of people who every day are watching our census. And what we do is we so-called flex our beds. So if we're having a certain level of COVID patients and we see it starting to reach what is our current capacity, we then take another unit or so in the hospital and we convert that to a COVID unit as we need to. So far we've been adept at doing that, but it's just common sense. At some point, if cases keep coming into us in increasing numbers to the point where it becomes more difficult to flex, all of us could become more strained and stressed in terms of providing the care. Other hospitals may not have that flexibility, or perhaps they're already at full capacity and are unable to change what they're doing. They've already eliminated elective procedures. They've opened up all the beds they can. And we could end up in a situation like Los Angeles is in right now, Well, for the first time in the US, I heard the term rationing care. That's a scary term. But what that means is that in LA right now, they're having to consider approaches that if somebody's in the ICU on a ventilator, they may have to take that person off a ventilator based on their underlying condition and put somebody else on. That is something that I saw happening in Italy back in March when I tried to sound the alarm about what this would mean if the epidemic got so out of control that we couldn't manage it. That's what we saw happening in Italy. I pray that that doesn't happen anywhere in Alabama, but I can't tell you that it won't, especially if we all aren't working together to stop the epidemic. The hospitals, the doctors, the healthcare providers, we can only do so much. It takes the community working with us in terms of protecting ourselves against infection, which is precisely why now is the time to rethink Christmas, knowing that if we all get vaccinated, next year's Christmas will be glorious because we will have the pandemic under control. If we don't do the things we know to do right now, I can't predict what January will look like for the hospitals, but I have a lot of concern about what it might look like if we don't do the right thing. And that includes up until the point of rationing care, which is to me reprehensible and quite scary, to be honest with you.
Thank you. Cynthia with ABC 3340 asks, people who have already had COVID think they are safe. What's the latest info on patients getting COVID a second time? And, you hear about antibodies and all of that. How long are we seeing antibodies reasonably lasting?
So we do have evidence that people can get infected a second time. It doesn't seem to be common, but it certainly happens. And it could be as much as 4-6 months after the original infection. So we're concerned about that, meaning if you've had COVID, that doesn't mean you can just go about the community as if you're totally protected. You aren't guaranteed of that. The antibodies last at least 3 months and probably as long as 6 months in most people. And beyond that, we aren't 100% sure. So I've seen some estimates out to a year, but here's the good news. The vaccine elicits antibodies at a much higher level than the actual infection. So the guess is that not only will it protect well in terms of the next 3 to 4 months after vaccination, but it's much more likely to last at least a year. And we'll know more within a year to know if another booster shot is going to be necessary a year from now for folks. But we know that people who've had COVID can get it again, to answer the question. Another question that comes out of that is, okay, if somebody's had COVID like I did back in March, should we get vaccinated? And right now the recommendation is yes, we should, and I did, but to wait at least 90 days after the first infection. I will say parenthetically that I've seen on the news people are criticizing President Trump for not getting vaccinated. In fact, he's still within 90 days of his initial illness, so he really shouldn't get vaccinated until 3 months after October, which should be maybe next month. But the point is, that's an unfair criticism of him because he's had the infection within 90 days.
That's good context. Thank you. I'm going to call on Miranda Fulmore with WBHM. Feel free to ask your question.
Hi, Dr. Slagg. It's Miranda.
Hi.
So you may be able to answer this. This may be a question that Savannah or Tyler could clarify, but I've had a lot of questions come in about hospitalizations versus ICU. I know I was on a call last week with Anthony Patterson, the CEO of UAB Hospital, and he mentioned that there's a total of 219 total ICU beds. Meanwhile, UAB Hospital reports, anywhere from, I think yesterday it was 185 inpatients at UAB Hospital. I don't want to alarm people if they think that we're getting close to that max. So can you kind of give me a breakdown of what a hospitalization is versus an ICU? Do they overlap? Are they separate? And just kind of better context, just so we can clear that up for our listeners.
Sure. Thanks for that. in general, I think about it as a Venn diagram. So you have the universe of people who are in the hospital. And then there's a subset of folks in this area who get moved from a regular floor into an ICU. So it's part of the overall hospitalization numbers. By the numbers that I last saw, which you should fact check with Savannah or Tyler, is that we're over about 200 total hospitalized patients, and the ICU number varies a bit. I don't even want to speculate right now, but I'm guessing that it's somewhere around 80 people in the ICUs. But again, we have the capacity to flex, to even increase ICU capacity based on the need. So that's something that I think we're really monitoring closely, and we're adjusting as we have to. The problem ultimately could become not just an issue of space and ventilators, which I think we're okay on, especially with regard to ventilators, but it might be personnel. We have to have trained respiratory therapists and nurses who are really skilled at doing ICU work. And it's not to say that other nurses haven't been trained in that historically, but they might have to be called into duty to do that type of work, as well as the physicians. So the stress goes beyond just the actual space. It's also the staffing of all those units. And PPE has to keep pace. And we've done a good job of recycling masks and being creative about how we create gowns and that type of thing. But the more we use, the more obviously that gets consumed and have to be replaced. So from my perspective, I just assume not see the surge. I'd rather us not find out where our capacity truly is. And the way that happens is by everybody in the community doing their part, like I've said earlier in this conference, doing their part to reduce their exposures for themselves and their loved ones, but also for our entire community. And that includes the hospitals and the hospital staff who work there.
Thank you.
Hey, Miranda and Dr. Slagg, this is Tyler. I'm going to jump in for just a second too, to help just kind of clarify a little bit. So yesterday, I think our numbers were 185 patients that we had in the hospital who were COVID positive. Then there were an additional, and I don't know the exact number, I'd have to go find it, but around 35 patients who were also in the hospital who had COVID, were hospitalized with COVID. They are no longer have an active case of COVID, but they are still hospitalized and being treated because they originally had COVID, if that makes sense. So these are folks who also wouldn't otherwise be in a hospital necessarily right now too, if they hadn't acquired COVID. So that's why a total census, like the number of patients that we're caring for is about over 20% of our census now is patients who either have COVID or who are still here because they had it and they're still recovering. They're just not well enough to leave the hospital yet and go home.
That's super helpful. Thank you so much, Tyler.
Sure.
And I'll just add too that when Dr. Slagg says we can flex up and down, we're fortunate that we can do that here at UAB. He certainly touched on the fact that we need bodies and people to help us manage that care. But it's also worth noting that that's also care that is likely taken away from others who maybe could be hospitalized, but we're having to turn a bed for something else. So that's when we're pleading for the public to wear masks, to social distance, to wash their hands. That's just that key reminder too, that we don't want to find anybody in a situation where that normal bed has been turned to an ICU bed, or for COVID care. So thank you for asking that, Miranda. Hopefully that clarifies a lot. Let's see who's next. Chastity Maxey with Fox 6. I think you had a question or two. Feel free to ask that.
Thank you, Savannah, and thank you, Dr. Slagg. I have a lot of questions actually, but I'm thinking about time as well. So first of all, I want to kind of piggyback on Mike's question earlier about talking about how to get the public to kind of buy into getting the vaccine. As a Black woman in my community, a lot of people have been talking about, of course, Tuskegee, and there's still very much concerns about whether or not you can trust your government to actually give certain groups of people the vaccine. So I just wanted to to possibly talk about what kind of safeguards there are out there right now to prevent something like Tuskegee from happening again, and could possibly convince people to get that vaccine.
Well, I think if we look back historically, there were a lot of injustices done from biomedical research, especially involving the Black community. And there's no way we can change that history. It is. But I think we've learned a lot from it since then. And I think a lot of those lessons have been applied to the development of this vaccine and the availability of it to all citizens in the country, no matter who they are and no matter what background they have. So I think, first off, just knowing that it's being offered to everyone is, to me, a huge step forward, that we're trying to minimize the amount of disparities between who gets a vaccine and who doesn't, or who is offered and who isn't. This vaccine is available to everyone. And so it's up to us to choose to get it. The second thing, as far as what is this vaccine? It's not a live virus. We're not giving people COVID. Rather, we're giving a very small fraction, a very small portion of the virus itself, what's called messenger RNA. But what does that mean? It's a little bit of the genetic code of the virus that's injected into the deltoid. Mine was right here. And then once it gets inside the cell, it does not interfere with the normal host, my DNA or your DNA. Rather, if you think back to basic biology, there's a cell and there's a nucleus. That's where the DNA is. This only goes into that outer portion. That's what we call the cytoplasm, or the part of the cell that's outside the nucleus. And then it uses the mechanisms to produce protein inside that muscle cell, and it starts, based on that code that it was given, starts to produce proteins that now the immune system can recognize and prepare a robust immune response should that person ever encounter COVID in the environment. And so that is basically how it works. Its safety is quite remarkable in the sense that there are some side effects, but as I said earlier, it's mostly local redness and a little bit of pain in the injection site that lasts about a day. And for a few people, like what I experienced, there's maybe some fever and chills, but that again lasts for less than 36 hours and is gone. And what's remaining is protection. And that protection is profound in the sense of 95% reduction in transmission to the point of symptomatic infection. And that's remarkable. I mean, we couldn't have asked for a better seasonal miracle, truly, in our lifetime than we're having right now with this vaccine being so effective and safe. So I certainly understand and appreciate, based on historical precedent in terms of how biomedical research was done in the past, but that's the past. We're in the present, and we're dealing with a huge pandemic. And if I had to weigh out, what is my risk of getting this infection in the community, especially with it being so prevalent there now, so present in our community, what's my risk of picking it up versus what's my risk of having any kind of meaningful side effect from this vaccine? That risk of infection is far outweighed by the benefit of the vaccine. And I would hope people understand that. As Dr. Collins said today after getting his vaccine, he can talk about this, but really what matters is members of each community. And I'm hoping that pastors and religious leaders step up, and other civic leaders begin to give a voice to this community forum, talk about this, because it's really going to take all of us together to bring the pandemic under control. And if we didn't have a vaccine, frankly, I don't see anything that would stop this pandemic over the next year or two, or possibly 3. I don't see it just burning itself out. It's going to continue, and this is our way to stop it.
Thank you. I don't see any new questions in the chat, and I don't see any new hands raised unless I'm missing something. So Chastity, if you had another question, feel free to ask it.
Thank you. I do have more questions. And then Dr. Slagg, you talked about, you touched on this a little bit already about how quickly we could get this pandemic under control. once everybody has access to the vaccine. Can you just talk more about that? How soon could something like this be under control? And also, can you still transmit COVID-19 once you get vaccinated?
Okay. Well, based on just basic epidemiology, we know that it's going to take about 65 to 70% of the entire population in the United States to get vaccinated for the pandemic to burn itself out. And the way that I think we can most think about this is think about a wildfire that we see on the news a lot from southern northern California. What keeps that wildfire going is fuel, and the fuel is areas around it where there's wooded areas, brush that can catch fire. That's the fuel that drives the fire and lets it continue. When we give vaccines, we basically take that fuel away. We reduce the number of people who are susceptible to infection. And after a period of time, once we get to 65, 70%, there's so little fuel for the virus and people being close together that it just burns itself out, just like a wildfire does, and we can move on. That's what we need to have happen. Your second question about can the virus be transmitted even if someone has been vaccinated? The answer to that question isn't completely known, but I can tell you what we do know. The vaccine doesn't necessarily completely prevent an infection, meaning if you go out and you've been vaccinated and you come into contact with someone who's got COVID and you breathe the virus in, it very well could bind to the receptor inside the respiratory tract and cause a brief transient infection. But now that the immune system is aware, it's gotten the intelligence from the vaccine that in its military operation, it knows how to attack and where to attack. It knocks it out just like that. That's how it works. And that's how it keeps people from getting sick when they get exposed and transiently infected after having a vaccine. The question you're asking is, when that transient infection occurs, is there production of virus within that person who got vaccinated enough to get into the environment before their body can knock it out to infect somebody else? The answer isn't essentially known yet, but my best guess is there'll be very little transmission. Why? Because it takes a lot of virus to come out of someone to create this cloud of virus around people to infect the next door neighbor or to infect the person next to them. When you have a virus that's been knocked down, it just isn't being produced in a large enough quantity, in my opinion, to get out into the environment. It's sort of like if you got infected and you're not vaccinated and you're wearing a mask, you reduce the amount of that cloud that's going out. And that's how masks work and why we encourage and really insist on their use as much as possible. So in essence, we can think about it as that we're putting a natural mask on the infection by giving a vaccine. And then if somebody's wearing a mask in addition to that when they're out, that helps it get to almost zero. So that's what we need to do. And it leads into another comment I think that's important. Everyone who's been vaccinated, after you get vaccinated, there's a tendency to say, I'm protected, I'm going to go out amongst my brethren and I don't have to worry. I get that, but what we should be doing until the entire pandemic is under control, everyone should be wearing a mask, everyone should be keeping distance, and everyone should be, as much as possible, staying out of large crowds, because that will help us, number one, reduce any possible transmission in case there is that spilling of virus into the environment around us that we might be doing unwittingly. But it also is a solidarity statement that while people are waiting for their turn to get vaccinated, everyone, if we're all doing the same thing, we're all wearing a mask, we're all keeping distance, we're all avoiding crowds, then we're going to be able to get this under control much more quickly and much more safely. So that's a long-winded answer, but I think you can take out of it what you'd like.
All right. I will say that Dr. Slagg, he did mention, has to go to clinic here soon. So if possible, if we have one last question, we can wrap on that, or we can just end there. I don't want to miss anybody, but I think that Dr. Slagg gave us a wide range of information and some really great points that should hopefully clarify a lot for audiences in our communities. So I don't see any other hands raised. With that, we will wrap this media Q&A. I will send a recording out. Oh, Chastity has one more question. We'll go there and then we'll wrap.
I am so sorry, everyone. Okay, just one last question, I promise. Dr. Fauci said that drug companies may start testing the vaccine on children pretty soon. What can you say about that, if anything? Why is it so tricky to vaccinate children? Is it because of dosing, or is it because we still don't quite know exactly how this virus works in children?
And can I just add one more thing to that? Would you mind touching on breastfeeding and pregnant women as well? Maybe populations like children that we just don't know enough about.
Right. Those are key questions. So whenever we have something new, be it a drug or a vaccine, we try to avoid the most vulnerable populations, which include pregnancy, breastfeeding, and young children. So like all studies, the initial studies that were done for both the Moderna and Pfizer vaccine were done in people 16 years of age and older. And so we have good data on those individuals, but for the most part, pregnant women were excluded, as well as breastfeeding women in general. The best guess right now that I have, and the maternal fetal child organization that advises what to do, best practices for pregnant women, recommend that women who are pregnant go ahead and get vaccinated. And the reason is that the risk of an infection causing bad illness in the mom while she's pregnant outweighs the potential risk of any harm of taking the vaccine, especially since we know so much about this vaccine in terms of what it is, how it's produced, and what type of immune response it creates. I think that that is going to be protective. For breastfeeding, it's kind of the same way. I think if we were dealing with a live virus vaccination, we'd be a little bit more, even more cautious, because that means that the person who got the vaccine would be infected with a new virus, and then you potentially be able to transmit the virus itself, either to a breastfeeding infant or to the baby in utero. But in fact, we aren't giving a live virus, we're giving just a very small fragment of it. So we all, I think, rightfully deduce that it's going to be safe in that setting. As far as children, the studies need to be done to absolutely nail it down. I mean, we could go out right now and start vaccinating kids, and perhaps we'll do that for some vulnerable children who might be immunosuppressed and need protection against the infection right now. But we're going to need to look at, as you suggested, the dose and get it just right. And that's going to take some studies. And we also want to look for any potentially unique side effects in children, which I don't think we're going to find, but we aren't going to know until we look. We could go out and just start vaccinating everybody and just look and see what happens. But in fact, I think it's better to be a little bit more methodical. There's going to be time anyway between the rollout of the vaccine. It's going to take several months for the sequence of people who are eligible for the vaccine to progress. That's starting with healthcare workers now, going to frontline workers, nursing homes. Then we're going to start with the older population above the age of 75, and then to immunocompromised, and then to progressively younger. So by the time we get to children, I think the studies will be conducted and we'll be able to answer the question more thoroughly. But this is what happens when they're in the middle of a ongoing pandemic. We'd love to have answers right now. We have to take them as they come and just be methodical. But above all, we have to have the ability to do these studies well. And I want to emphasize again, the vaccine studies that have been done were state of the art. They were the best methodologies that we've ever had for development of any vaccine. And I take a lot of confidence and knowledge in that. It makes me feel good that we've done it right.
Thank you for the question, Chastity, and for all of your answers, Dr. Slagg. We really will wrap now with that. Thanks for all your time. I will send out a recording of this video here once it uploads. So stay tuned for that. As a reminder, please keep pushing for folks to download the Guide Safe Exposure Notification application. And hopefully this will help with some of those questions and reporting over the next few days. We hope everyone has a safe holiday. Please keep stressing that messaging of mask wearing, hand washing, etc. as well. So thank you all, and Merry Christmas.